how are you? Can you hear me?
Of course.
Yes. This
Good
is
morning, Dr. Park.
yes, and thank you. And this is our last session, the live demonstration. And so our team is the same team in the yesterday.
We'll try to be less entertaining.
Yeah. Okay. This is another valve in valve. Yes. So, you know, yesterday the patient was final result was excellent, and the whole regional wall motion abnormality was resolved, and there is no mild AR after checking the final echo. Patient recovery well. Patient is stable. Very luckily, and the result was excellent. So today we also prepared the similar valve case. I think this time is a very good time to share our knowledge and experience the David Cohen. And so I'm gonna introduce our team. It's David Cohen. Will do the procedure, and the Dr. Gang and the Dr. Kwon. Okay, Dr. Gang, can you briefly introduce the patient?
Yes. This patient is a 66-year-old male who was admitted for dyspnea. And he received surgical AVR with C perimount 23 millimeter due to infective endocarditis 13 years ago. And now the echocardiography showed severe eccentric AR due to prolapse and moderate aortic stenosis with thickening of the tissue valve. He also has an alcoholic LC, and he is on heavy alcoholics. Next. His STS score is 3.6%, relatively low risk, but he is on a chronic alcoholics, and he already received surgery, and he eagerly wanted the interventional treatment. So we did a heart discussion and fully discussed with the patient and patrons, and we decided to do the valve-in-valve procedure. Next. And his echocardiography showed the normal ejection fraction, and peak mean pressure gradient was 59 to 31, and peak velocity is 3.8. And he showed severe eccentric AR with moderate AS. Next. And this is the CE perimount 23 millimeter valve. It has the true inner diameter of 21 millimeter. Next. And for this valve, Sapien 3 23 millimeter or Eberhard R 23 millimeter is recommended. Next. This is our CT analysis result. The valve internal area showed 324. Next. And the CT shows large sinus valsalva area and ST junction area, different from yesterday's case. The sinus to annulus ratio is about 2.5, very large, and ST junction to annulus area ratio is also 2.4. There's very big room. Next. And LVOT size is also big. And next. And the CT shows the coronary height is more than 10 millimeter, about 11 for left coronary and 15 for right coronary. Next. And this is a sizing chart for Sapien 3, and if we implant a 23 millimeter Sapien 3, it makes the 26% oversizing. But it's according to the CT measurement of the just inner diameter. It is different from the actual
After
situation.
seeing the hemodynamics and after seeing the trans-esophageal echo finding, the David and we're going to show the treatment strategy. Looking at the hemodynamics, can you see the hemodynamics?
No, not yet.
Yes. Yes, it's now visible.
Okay, 위에 거? Okay. Looking at the hemodynamics, there was a moderate AS, and we can see there was a severe AR component, and we can see that. And also, the Dr. Kim and the echo specialist standby do the trans-esophageal echo.
Can you show the echo images?
Can you explain the
please follow the arrow on the screen during my presentation. This is an image from trans-esophageal echo, mid-esophageal long axis view. You can see a second bioprosthetic valve with steno chest. There's a big echo drop right here, but the big picture here and consistent with the severe aortic regurgitation, eccentric. The pathology of AR is, please look at the three-cross biostatic valve, heavily calcified and thickened. You can see a coarctation defect right here. Unless I measure the area, this definitely severe AR. You can see a laceration of left coronary goes from here, and maybe 2 jet occurs during diastole.
Okay.
And no paravalvular air?
Yeah, I carefully just
Okay.
today.
Outside of a valve, there is no PVR.
Yeah, no
So
paravalvular
definitely be sure.
Yeah, we should be absolutely sure. So
Yeah.
do we have the aortogram now you can see? That was done in the nice coaxial implant view. And what
Yeah.
the difference with this case compared to yesterday's case is that the sinuses are much larger, the coronaries are higher, and so I think if we need to fracture this valve, it will be, there's much more room. Again, we can measure that on the CT, and what we put a virtual 23 millimeter valve in here, and there is plenty of clearance to the coronaries. So we're not worried about coronary occlusion. We're not protecting the coronaries or anything.
Yeah, we already checked the coronary angio.
Yes.
And the next view, and the
Oh,
next.
sorry.
This is right coronary. The right coronary is okay. And next, this is a left coronary. The height is 11. It's a left coronary is okay. So David and we discussed the patient strategy. We decided we're gonna do valve-in-valve and with Sapien 23, and after that we're gonna check the hemodynamics again. If there is a substantial some AS component, something like that, we're gonna do sequentially the balloon fracture. So any comment question from audience and any another thought for that?
Thank you, DW and David. So obviously you can approach a valve-in-valve using 2 different valves. How would you decide here using an S3 versus an Evolute?
I think, I mean, this is one where I feel like we could use either. I think an Evolute would work very, very well here. The thing about it is, if I was going to use an Evolute, it's recommended for a 23 Evolute, but if I were going to do that, I would almost for sure plan to fracture it, and I would put a 26. I would go a larger size for the Evolute in anticipation of possibly fracturing it. This is a valve where we may not need to fracture. It's a 23 millimeter valve, so it's not a small valve. The inner diameter is 21 millimeters, so we expect when we put in the 23 Sapien, it will be somewhat constrained, but not aggressively constrained, and we'll see what the gradient is. But I think either way, it should be fine. It's not so small that I'm worried about that we need to do it with a core valve to minimize patient prosthesis mismatch.
Actually, the size of the surgical valve in the diameter is 21. Is relatively short, the smaller, and even though you deployed the Sapien 23, it's still small.
Yeah.
Maybe this patient age is 66.
Right. He's
10
young.
years later, maybe the still very small valvular area.
Yes.
So
So you
what
think
about the selection of the other valve system? This is the annular, but if you select the Evolute R, is a supra-annular.
Yeah, it might be a little lower.
We have to think about the 10 years later.
Yeah, I think if we fracture this valve, though, we will get what we've seen is that the fracture procedure basically makes the Sapien perform just like a Evolute R. So we have data now from 75 patients, and what we see in that is when we match the patients, as long as you fracture, it doesn't matter that, the things that we've been taught about needing to use an Evolute to minimize the gradient are not so true.
The U.S. center is Kansas City. The U.S. center is do a lot of the valve fractures. So how many patients treated balloon expandable Sapien series? How many?
So we do most of ours with core valve. I mean, that's our most common.
Most common
to do with core valve, because again, I do think even when you have a very small annulus and you fracture, I think you still could get a little bit better. We're very comfortable with the core valve. This is a case this one could go either way.
Yeah,
so
my memory, the publication in the circulation interventions, 30% use the Sapien, 70% use the Evolute R.
Exactly. So I think, I mean, this is a case where I asked DW what he wanted to use. He said, I want to use a Sapien. So I said, okay, that's fine. But I don't think it would be wrong to use a Evolute R either. It would be fine.
I have a question. So after the surgical procedure back in 10 years ago about,
14,
do we have
13.
any data of what is the residual gradient across that surgical valve? Because I think that's very helpful to know when the valve was functioning normally, was there any mismatch?
Was it okay? Yeah, I don't know.
Yeah,
Do we know that?
definitely.
I don't know.
Yes, as you mentioned, Arlen is definitely the PPM, the patient prosthetic mismatch was definitely a real problem. So based on literature, 20-30% usually shows the PPM patient prosthetic mismatch after surgical valve. I don't know the reason why. Is there any cardiac surgeon? Is there any comment for that? Usually the cardiac surgeon prefer the slightly smaller size surgical valve. Is any comment from cardiac surgeon on the panel? No cardiac surgeon?
Yeah, do we have any cardiac surgeons on the panel?
We have one surgeon in the floor.
Okay.
He's a quiet surgeon.
Okay.
We don't have any of those in America.
Okay, so I'm gonna slowly progress our procedure. This is we already put the pigtail caster, and this is sapphire wire, sapphire 2. Okay, got it. Okay, slowly. Okay, and then valve prep is okay. Okay. Okay, got it. 자, 밸브 한번 넣어보세요. And then after implantation, sapien 3, we will check the hemodynamics again, and then we will see. Okay, this is sapien 3, 23. Okay, got it. 뒤에 잡고. Okay. 네, 23mm 노미널이죠. 자, 밑에 보여주고. 오케이. The peripheral is okay. 그래서 자, 와이어 보고.
Good. Wire's good.
와이어 보고. Good spot. Okay. Okay, you can do that. 와이어, 도윤이 와이어 잘 보고.
You got the wire?
Okay, got it. Okay, great. Wonderful. Okay, got it.
Good. Okay. Okay.
Okay, got it. 자, 오케이, 다 됐다. 조금만 더. 오케이, 됐어. 오케이, 됐지? 자, 들어갑니다. Okay, I'm gonna make a band. This is already make a band. Okay, got it.
You have wire?
자, 플라너 라인 맞추고 도윤이는 저기 그것만 신경 써.
So let's go to the
와이어만.
deployment view.
Okay.
What's our view?
Okay, great. I removed some.
So we are not in the same view before?
Yes.
자, 플라너 가고.
Good.
이거 피그테일 와이어 좀 줄까? 자, 이거 얼른 줘. 스티바이 얼른 줘. 프레시 괜찮고.
So you really don't need the pigtail down for this at all?
Yeah, it's
Because we see where we are?
okay. Okay, I'm gonna check it.
But you can put it there.
야, 그 준비를
Might as well
해.
put your catheter back first.
됐어?
The
Okay.
we can.
okay,
We're
got
just
it.
he's messing with the pigtail.
아, 자, 피그테일 좀 넣어놓고. 여기 띄워놓고 딱 스탠바이 하고 있어야지. 오승이 신경 쓰거라.
Yeah.
Okay, got it. Okay. 이렇게 놓고.
So this is a case where you really don't need
이거,
the
이거야?
angiographic pigtail so much
맞습니다.
because we have the
자,
nice
빼고.
markers from the valve.
자, 이거야? 자, 에어 빼고 테스트 살짝 한번 해봐. 프레시 있어, 오케이. 자, 테스트. 오케이, 들어갈게. 자, 오케이. 호뷰로 한번 가봐.
포플라나 뷰 맞습니다.
오케이, I'm gonna do that. 포플라로 맞아?
네, 밸브를 패럴하게 맞췄습니다.
오케이, got it.
Come back a little more. You
Yes.
You happy
Okay,
there?
you got it. It's I'm gonna slightly pull back over there. 자, 테스트 한번
You
해볼까?
want to bring the push the catheter back a little? Or you leave it there.
Okay. Okay. I think the position is okay. How about that?
The delivery sheet may come back more. The
Yeah,
pusher needs
that's
to
what
come
I'm
back
looking
more.
at.
Okay, got it.
Yeah. Just bring it back.
Usually it doesn't.
One dot, there
It
you go.
doesn't matter.
Yeah, you don't
Okay.
want to get
Okay, got it.
here. Okay, so we will do a slow.
Yeah, patient is pressed. Okay. How about the position?
So I come up a
Test.
little. Yeah, come up just. I don't think you need to test at all.
Yeah.
You just worked off the valve, so come up a little bit. Come.
The
and,
up part?
aortic, yeah.
Yes.
Just a little.
Okay.
Okay.
Okay. I
Good.
think
I
this
think
is
it's good.
good.
Okay, and we'll
자,
just
다
slow.
준비됐어? 내가 중간에 스탑할 수 있어. 자, pacing on. Okay, inflate.
And go in a little bit. Go in a little bit.
Yes. Okay, got
Okay,
it.
here we go.
Go in a bit.
Inflate. Okay, good, good. Okay, 1, 2, 3, 4, 5. Deplete. Okay, pacing off. Okay,
That's a
we
little
did it.
lower than I wanted, but I hope
I
it's
think
going to be
I
okay.
think position is okay.
That definitely went in a
자,
little bit
이거
deep.
뒤로 빼보자. 자, 이퓨전 괜찮고 브레드 프레시 괜찮고. 자, 한번 에코 얼른 한번 봐주시겠어요, 김 대신? We're gonna
Please
check
give me
echo.
sufficient time to evaluate.
We're gonna remove the tension, the wire.
Yeah. Well, that's I definitely would have liked that to have been 3 millimeters higher.
I think might probably like from the mitral valve junction.
Dr. Kim,
Yeah,
please comment about
Yeah,
the
please
echo
comment.
finding.
Yeah.
yeah.
Can you hear
Can you
him?
see the image right now?
Okay.
Yeah, you can please follow the arrow on the screen. You can see a small jet from the mitral valve junction.
Just a little.
Yeah, just listen, but trivial to mild or something like that. Yeah.
Trivial. That's trivial.
I changed the view into short axis.
The result is good.
It's good, yeah.
It's just the trivial.
It's a little low.
So okay, at this time, we're gonna check the angel. 준비됐지? 같은 뷰야? T 조금만 빼주세요.
Actually, in our
간다.
institution, the imaging
푸샷.
specialist determine,
Good. Excellent.
advise us
So we're gonna
the
check the peak test.
additional treatment or not based on the
zoom해서.
transesophageal
조금 더
finding.
넣어.
So,
가이딩을.
Dr. Kim, did you say that is
We will
minimal?
check it,
So you don't need we don't need any more touch.
Yeah, I agree. Yeah, with your comment.
Okay.
Yeah.
Only
Second
for-
one is the pressure itself is very
And then peak
excellent.
test.
If it is available, please calculate the effective orifice area. Actually, the size of the sapien in 3 is a small size of it, and we have to be, anyhow, the patient have a favorable long-term follow-up, but the effective orifice size is smaller, is a little bit uncomfortable. So please calculate the
Okay.
area.
자, 와이 잡아.
Doctor, you mean using echo?
I think he's means
Yeah,
course.
it's challenging because the transgastric be maybe optimal for the. I'll try. Yeah.
We will measure the gradient the old-fashioned way by hemodynamics.
Yes, this is we do our routine. 근데 이거 연결해 바꿔야지. Okay, got it.
This is transgastric.
자, patient blood pressure, the vital status is excellent. Okay.
Yeah, can you see the
에어 빼고 we will check again. 사진 한번 연결해 줘. So,
So
you
measure
know,
the gradient.
looking at the pressure gradient, just a little, you know, the stenotic component, but the AR is AR
is
index
wonderful, yeah.
more than the 3 point, you know, some
So-
30, more than 30. It's just a minimal AR. It's
Can you see the CW tracing of the new valve?
So do you
Yeah,
have a
peak
gradient
velocity
on the
just
echo?
2.4. It's excellent.
Let's evaluate.
It's can you measure the gradient by echo?
Yeah, the peak. Wait a minute.
Looks like about 10.
The peak pressure gradient 23 millimeter mercury.
This is okay.
Peak at 23, what does
it's
it
a,
mean?
excellent result. How is the pressure monitoring?
I'm sorry?
How is the pressure, invasive pressure monitoring?
What is your mean pressure on invasive measurement?
So our mean arterial pressure is 74.
The mean gradient
I don't know if somebody
Yes,
can
yes.
somebody calculate our mean gradient? Are they doing that?
74.
from your system, yeah.
Yeah.
from your-
I mean it's not
Yeah,
bad.
The Doppler angle is
That's very good.
excellent.
Please.
That it is an exact result. Yeah. No more than 2.5.
No more than
Very low.
2.5.
Yeah.
I
Very
think
There's
looking,
hemodynamics picture
yeah.
now that doesn't look like there's much gradient.
No,
yeah,
we
you know,
did
so
change
looking at
something
this
a
is
little bit.
our final the hemodynamics. Looking at the significant the pressure gradient.
Right. It always goes up a little bit,
yeah.
of course, when they're not under anesthesia.
Yeah, it's how about the, you know, Cohen? Do you think we require valve fracture?
I don't think it
I don't
is.
think so.
I don't think so.
This is,
I agree.
I would feel bad. I would feel bad if we caused a problem.
Yeah. How about the panel's opinion? Is anyone to want to valve fracture?
So a question again. So when was the valve put in again? The surgical valve, 2000 and
2005, so it's 13 years.
so 13 years. So likelihood that was actually pretty well matched, because if he has had problem with prosthetic mismatch, he would have much more problem earlier.
Yeah, I agree.
So he failed by the leaf that was, obviously
By
prolapsed
AI.
and
Yeah,
destroyed.
definitely.
So likelihood is that you would not need to have a fracture if there was not whole lot gradient post-surgical.
Yeah, definitely.
So I think that's kind of retrospective, obviously not, completely predictive.
Yeah.
But seems like
Yeah, I think it's
consistent with this history.
Yeah, I think, the stuff that we don't know, we talked about this a little bit yesterday, is, if we knew this was perfectly safe, I would say fracture it because it will make more room for the third valve.
Definitely.
When he needs another valve in another 10 years or something like that, we could have a little bit more room to put that in.
Definitely.
But we probably could even fracture it into, when we come, if he comes back again with a problem and you put a core valve or you put a sapien in, maybe then you fracture it at that time. There's no reason why you can't fracture through two valves.
Definitely.
For that. So I think right now, I think we are good.
Yeah, I think this is based on hemodynamics, echo finding, and based on the, some panel's opinion. I just
I came all the way to fracture a valve. though.
removed it, and then I'm gonna check the hemodynamics. The final is an angiogram, and then we will check again
Yes.
transesophageal echo. Okay, T 조금만 빼주시겠어요?
Window ready?
이거 준비, 이거 연결해야지.
네, 바꿔주시면
요거죠?
됩니다.
So, and David, you have a lot of the experience and expertise valve fracture. So, for audience, could you comment about what the patient would be a good candidate for valve fracture or not?
So
Is
a
it
good
definitely-
candidate for valve fracture is a patient who has a small valve. So
Small
it's
valve,
usually a 21 millimeter surgical valve or smaller, which about half of them
됐어,
are.
준비됐어?
And a patient who has an unacceptably high gradient after we implant the TAVR. So if we put a TAVR in and we have a gradient anything over 20 for sure, we would want to fracture if we can. If in our hands, because we're very comfortable with the procedure, we usually will fracture if it's over 10. If it's under 10, we won't do it.
You just, okay,
So
got it.
it's but we like the procedure. We think it helps the TAVR valve function a little bit better. But this one was, this is totally fine.
Definitely,
And I think,
definitely.
but what we also know though is, again, the gradient is 5.
Yeah,
now, right?
definitely.
Tomorrow, when he wakes up
Yeah,
and gets a
yeah.
transthoracic echo or
Yeah,
30 days,
yeah.
the gradient will be 10. It
definitely.
always goes up.
Okay, definitely.
Then, so you have to think about that a little bit as well.
Okay, 자,
I
준비됐지?
have a
ready.
question.
Yes, please.
자,
So
풀샷.
if you need a fracture of the surgical
Excellent.
valve,
아래요.
do you do it
넘어가보죠.
before implanting the
크게도 안 세는데?
TAVR valve, or it doesn't matter,
The,
whether you do it before or after
조금
the
내려서?
implantation of TAVR?
So we talked about this a little bit yesterday. There are arguments both ways
풀샷.
to do it. We almost always do it
Excellent.
after we put the TAVR valve in. The reason we
한번
like to do it
파이널
after
T 좀 한번
is
봐주세요.
좀 볼게요.
because,
네.
first of all, we get to assess whether the gradient is bad enough to warrant it. And number two, we think the TAVR valve helps to capture any debris that might be liberated by the high pressure inflation.
Yeah,
The disadvantage of that is that we may be damaging the leaflets of the TAVR valve, and perhaps we are making it less, have a shorter lifespan, which we don't know that.
Yeah.
But that's a theoretical disadvantage.
Yeah,
So other
definitely.
people, want to fracture the TAVR valve, fracture the valve first, the surgical valve, and then put the TAVR valve in so
Yeah,
that they
yeah.
know that the TAVR
Definitely.
valve
Can
has
you
not
see a
been
trivia
disturbed.
like from
Yeah.
the monograph?
The disadvantage of doing it that way
Right
is,
here.
again, you don't know if you really needed to fracture.
Yeah.
Because
You know,
you
some
can't assess,
yesterday we have enough time to discuss some, after valve, the coronary obstruction risk is very high. It's a very interesting paper is published the JAG intervention a couple of months ago. It's like a basilica.
Yep.
Dr. Khan is developed NIH, some suggest porcine model and also 3 or 4 patients
Yeah,
they
they did
do
some cases,
basilica.
yeah.
Could you comment about the basilica?
So,
Is
so
it
I've not done
feasible?
it, but it's a procedure that is getting some traction. If you have a case, the case we had yesterday was a perfect. We said it even before we started. Was a perfect case for basilica because the coronary, the leaflet of the surgical valve came right up to the top of the coronary, and it was very close to it. And we knew if we fractured, we were going to obstruct the coronary. And if I was comfortable doing the basilica, which I am not yet, I would have recommended we do it. So what the basilica is a procedure where you actually split the prosthetic valve leaflet, or you can do it
prosthetic.
with a native valve leaflet. But you do it by taking a very stiff wire, a Stato wire, which is a peripheral wire. You actually poke it through the leaflet at the base of the leaflet by echo guidance. You snare it, and then you electrify it. You use a cautery, a Bovie catheter, and you actually pull it up, and it makes a slice. Through the leaflet. And then the leaflet is away from the coronary, and you can have much less chance of occluding the coronary. So it's obviously is a complicated procedure. If you read the paper in JACC Intervention, the patients do get some AI, obviously, if you tear up one of their leaflets on purpose.
That is our next year.
Next year, please? Okay. Every year they make me do something more complicated. That will be fine. Hopefully I will have done one by then, so we can know how to do it.
Okay, looking at this is our final angio, absolutely the nice result, and the next view. So this is audio view. There is no evidence of the AR. And then the final, we're going to check the transesophageal echo.
In transesophageal echo, just the trivial paravalvular leakage and no evidence of complication. Every function looks good, normal.
Good. All right, we're happy. Much easier.
Much
easier than
I want to ask Dr. Kim, our echocardiographer, that we typically, when we check the echo tomorrow, the gradient is a bit higher, meaning that obviously a lot of times we attribute the patient being asleep during the procedure.
Yes, sure.
May be
because
lower.
Systemic vascular resistance decreased right now after wake up.
There's also another possibility that as you measure your pressure gradient from echo is really right at the valve, and we measure hemodynamics at the with the pigtails above the valve typically, and there's this phenomenon of pressure recovery that typically you get a higher gradient at the level of the valve, and once the sort of the pressure dissipates, your gradient actually in reality is lowered. What do you think? Do you actually look at sort of the pressure recovery measurements of valve gradient?
In real world, we always calculated the pressure recovery, especially the aorta diameter is small. In Asian patients, small body subserial women, we always calculate the pressure recovery whenever available. Very important issue in Asian people.
Okay, so our live demonstration today is very simple, relatively to yesterday. So everybody, I hope to expect a basilica procedure with David Cohen next year. Thank you.
Thank you very much.
Thank you.
Excellent. Good job.
Thank you.
Wonderful. All right.
Dr. Ahn?
Yes.
Dr. Ahn and Eberhard, you're up next.
Evolute team is back.
Okay, would you go ahead?
Yeah, thank you very much again. As you can see, I'm very comfortable here together with this wonderful team, and I can tell you we have a very, very interesting case for you that Dr. Ahn has selected. A lot of teaching and learning points, so this is not going to be a straightforward case. And I would like to mention at this time that I'm very happy to be back here and do this case with him and with his team.
Okay, Dr. Lee, could you introduce patient history?
Yeah, okay. Let me see this case. 69-year-old male was admitted with DOE, dyspnea. 18 years ago, he had permanent pacemaker because of complete AV block, and he also underwent band therapy because of periaortic abscess and cabbage 16 years ago. Actually, he previously he was diagnosed as a Bechet history. We examined the echocardiography findings, showed severe AR and severe MR. S score was 2.9% low risk profile. And echocardiography showed severe AR and severe MR. And the LV ejection fraction was 44%, so mild LV dysfunction. And the coronary angiogram showed patent previous SVG graft and mild disease. Okay, next. This is the prima root 25 millimeter hip gift. So stainless tissue valve like this. Next. And true inner diameter is 23.5 millimeters, and it is compatible with Sapien 3 and Evolute R. We also analyzed with the CD, CT, and the annular perimeter-driven diameter is 19.6 millimeters. And the sinus portion and sinus tubular junction is enough compared with the annular area. And also alveoli is enough, okay. Calcium was seldomly found. Okay, next. And this is the important issue. And left coronary artery is quite low, so it is a risk of compromising. Yeah. So, Dr.
Yeah. So I think this is not easy case. Actually, the reoperation is not easy. My surgeon transferred this patient to me because of SDS score is very low, but technically reoperation is not easy. So I think this is a good indication for TAVR, even patient age is very young. But as you know, the TAVR in the stainless valve is very difficult because of sizing and then low lining left main, as you can see. So the step-by-step with the discussion with the excellent panel and Dr. Grube, I'd like to show you the nice result.
Yeah, Alan, I think, you know, this is really not a straightforward case. There are many things to discuss, and obviously the very first one is the indication. I think we could agree, based on his previous surgery, that a redo carries, you know, a considerable risk. So I think the TAVI indication is here in this patient a good one. Also, you know, the 2.9 doesn't really reflect the technical issues and the difficulties that we might be having. So I think, you know, putting this all together, I think it is a good indication for a TAVR procedure. Now, the question is obviously, you know, Sapien or Evolute. And it's not because I have more experience with the Evolute, but I think when you do a stentless valve with not much marker points and the coronary low, I simply I would prefer the Evolute in this case. You have a little bit more tolerance, as David pointed out, in terms of actually even sizing and positioning, plus the low coronaries. So I would personally vote for an Evolute approach over a Sapien approach. The other thing is, if you look at the angiogram now, you can see the coronary is low, but there's a big sinus there. So we discussed beforehand whether we should protect or not. To be honest, Dr. Ahn and I always, or most of the time, agree. Here, I'm not really concerned about obstruction. So I thought, you know, for two reasons. Number one, the big sinus. And number two, with Evolute, we have a chance. If there is any obstruction or we see any distance changes between the coronary and the valve, then we can always retrieve it. So we are on the safe side, and we both agreed that we would not protect the coronaries. As I said, Alan, I think the most important, or a very important point to bring across to you and the audience is to be aware of the potential problems instead of being surprised by it. So that's why I'm discussing this. And then, as you can see, there's one thing that is a little bit more difficult and probably good to discuss. You see there is a little indentation above the coronary or above the sinus at the ST junction. Can you see that?
Yes.
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 So that is a little bit of a concern in terms of sizing. Remember, we discussed the 23 and the 26. It's in the middle of it. And we discussed the 23 and the 26. And initially we thought maybe we get, you know, by the diameters, we get by with the 23. However, given the fact that this is a leaking valve, more insufficiency than stenosis, I'm a little bit concerned that we might not actually have enough radial force. And we discussed what are the downside and the upside of taking either one of those. If we take the 23, there is the only downside for the 23 is that we don't really seal well. And then we have to do a post-dilatation. But we cannot really post-dilate the way we normally do because we have this indentation and we don't want to rupture that. So then what is the downside taking the 26? The 26 has better radial force, a little higher radial force, and the chances that we have to post-dilate in this insufficient valve is lower than with the 23. Yes. And really, it's a 3 millimeter difference. I don't think, as far as the constraint is concerned, with this little indentation, there's no downside taking either one valve. Remember this little indentation there. I don't know what the sizes are, but you know that might constrain the valve, and therefore I voted when we discussed and basically decided to take the 26 over the 23.
So Eberhard, just so that we all understood what the prima root is basically a porcine root that is about the height of where the constraint is. There's where the porcine root was sewn into this person's aorta.
Correct.
And then the valve, the leaflets obviously are porcine, and then the sinuses are porcine. And what happened is the surgeons cut off the left main of the porcine coronary and reimplant the left main to that spot. So typically those sinuses are pretty good size, and the button usually have a flaring nature to it. So I think the obstruction risk of left main is relatively low, as you said, because the size is, I don't know what the size measurement to be, but probably looking at it, also the tilting angle, I think that doesn't need to be worried too much. The right coronary is gone, right? It's been bypassed.
Yes.
Is that right?
Right.
Yeah, just to make sure. So I think that's sort of really understanding this anatomy here. Have you measured the height of this prima root to that spot? You can measure on CT pretty easily, right? So you know where your core valve is going to land in that situation.
Yeah, it lands in the tubular part. But I don't think, and I would not hope, that it would constrain that much. But in case it does, Alan, then the 26 would have a better expansion than the 23. There's one. Oh, I forgot. One more thing.
So
we discussed another thing because you don't have any markers here. You know, you are. So we discussed a little bit the dual pigtail technique, but actually we decided against it because first of all the coplanar view is very good. It has two pigtails. There's much more going on. So Dr. Ahn feels very comfortable to have this marker and the non-coronary sinus as a marker for our delivery, and I tend to agree with that because, you know, given that indentation there, the chances that the pigtail will not stay is high, and then why you know, do it anyway? So because you can see you have to bend the pigtail to put it into the left, so I think we're going to be okay. I just wanted to mention it. This is an option when you have, as we saw yesterday with Dr. Petronio, you know, as a marker. But at the end of the day, the two pigtails always, they're not very stable. And the 5 French, when you move the valve in, you know, they usually dislodge anyway. Okay, so
one more thing is have to discuss is mitral regurgitation. This patient have a severe functional mitral regurgitation.
Doctor, please note that the functional are much reduced, mild degree.
Oh,
You
really?
treated well before the procedure.
So I prescribe the large dose of diuretics. Okay, no problem. But
So do you use the size of the Eberhard R is 26, not 29?
yeah,
No.
26. Yeah,
26.
26. Yeah.
And actually we have to know that actually the rationale for this patient for the TAVI is actually young age, but he skipped some presentation of the. I saw that the patient history is a Behçet
Yeah.
disease.
Yeah.
Yeah.
Is that the surgeons really hate it.
Yeah,
The- in the
You're right.
Behçet is when the surgeon is sutured, it makes some easily tear and easily to inflammatory change. So maybe that is the one of the lesion of the peri-aortic abscess and refuse the repeat
yeah.
surgery.
Yeah.
Okay.
Okay.
Well, thank you for the comment. Very, very important. Okay, now, no, go ahead.
Yeah, thank you.
So we'll see. I think this is quite interesting, and you can see. I don't know whether you can see the echo, but the echo shows very nicely this little suture line, or where the
The sewing
root,
ring was right. Yeah.
where the root was sutured to the original aorta. Yeah, very nice.
Okay. Sewing ring is below. Yeah. So comforter wire.
Safari wire.
Safari.
I don't think Confida is approved here,
Yeah.
Alan,
Oh,
believe it or not.
okay.
가까이 주세요.
Do you notice any differences between the Safari and the Confident?
Well,
pretty
in
much using
theory,
Confident
I can tell you, I can tell you, in Germany we are exclusively using the Confida over the Safari. When the Lotus was taken off, we even use it for our Sapien implants. So when Lotus comes back, then we might have to use the Sapien again. I mean the Safari again.
I like the comforter a lot.
Yeah.
It's stiff enough, but not too crazy.
Yeah,
And then it's
exactly,
very good for
exactly,
transeptal mitral valve, transeptal, tricuspid valve. It has a nice curvature, but not too stiff and not too soft.
Yes, I agree.
After hearing that this patient has Behçet's disease, a thought comes to my mind that if there is any need to avoid contact between, aorta R, the frame, and the native aortic aorta, because of chronic contact that may cause
Ulcer.
inflammation.
I don't know enough Behçet's that what happens in
It is 18.
but obviously it's an ulcerative type of disease that is in mucous membrane and so forth. So I think it'd be something to check beforehand would be quite good too. But obviously at this stage, his valve and endovascular procedure like TAVR will be probably better than an open surgical procedure.
See, what I really like, many things that we might overlook, but he never loses the sight of the wire in the ventricle. You've seen this morning, Alan, the ventricle was beaten pretty hard with that Landerquist, and the result you saw, So this is always a good thing. Those are minor things, but they're still important in order to avoid, a complication.
So
you have checked the Evolute pedals already,
Yes,
right?
Yeah,
yes, we
already.
did
Because
before.
we didn't see on screen. So.
Yes. It was a good load, so
It's always compulsive. It's always good, right? So never skip any steps of any kind, right?
yeah.
줌을 하나 풀어주면 다
네.
전 화면에 좀 볼 수 있을 텐데.
좀 풀고.
Back of it. That's why.
위로 올라갑시다.
I hope that the pigtail will stay in place. I have a look at the pigtail. Yeah, very nice.
Test please.
Can we magnify just for the old man?
오케이. 좀 더 해주세요.
That's good.
오케이. 테스트. 오케이. Axiality is not good, but
The pressure is a little on the low side here.
okay. I like to starting here,
Yep.
and then we'll adjust. Test please.
Okay.
He's giving me the directions.
예. 그 디바이스 디플로잉 앵글로 바꿔주세요.
I think there's not much parallax on the ring, so that's why you can probably do that okay without having to change another angle.
Yeah.
Okay.
You're changing the angle a little bit now, so
Yeah,
that's
now.
good.
Test please. Okay.
Too much.
Wishes please. Okay.
A little bit ambitious here, huh? Yeah, because you know that's not calcium here. You know that's a little
Right.
bit the situation for the anchoring.
Test please. Okay, good.
So you can see he stays a little deeper.
Yeah, I know. So, okay, release please. Okay, good. Test. Okay.
Still good. I think I like
Yes.
that depth very
Yes.
much.
Okay, good. Release. No.
You can see.
See, there's no calcium here.
Yeah.
No calcium.
Have to do it slower,
The
probably.
main component of the disease is the aortic regurgitation rather than the aortic stenosis. So if you do the next step, what about some ventricular pacing?
Yeah.
Yeah.
That's a very good point, actually, and I would consider it, to be honest.
And slightly deeper here is not a big problem, right? He has a pacemaker
Yeah.
already,
Yeah,
right?
he has a pacemaker anyway.
Slightly deeper because it's going to pop otherwise. It's hard to be perfect in
Test.
that location.
Okay, good.
You tell me when you want to pace, right?
Yeah.
Keep going.
Keep going. Test please. Test. Okay, keep going.
Can we move the thing a little bit closer?
Okay. Keep going, please.
Yeah. I'll be very careful now.
Test. Okay, keep going.
Watch it. It's
Okay.
coming out again.
Okay. Blood pressure is down. Okay. Okay, see. Just a moment. And then, ready?
So very deep on the left side, but then it laid back. But
Yeah.
maybe it's too deep.
I mean,
And then lay on the other side, but
if you go higher,
yeah. Maybe one more time, try a little higher.
let's see, what is the... you see, because, you know, you can't really push the valve into the coaxial position because of the lack of calcium. What do you guys think?
So try to one more at the high position.
A little bit higher?
Yeah.
A little bit higher, maybe.
Don't resist too much.
One of the uncomfortable situation is the
And
coaxiality.
oh no, yeah.
The evolutal is not ideal.
Yeah.
Okay, not easy. So the heart rate is 970. Pacemaker를 how about the control the pacing?
Yeah.
Yeah.
I think I would do controlled pacing. Remember, now the diastolic pressure is 30. We deployed the valve, and the diastolic pressure was 60. So
Yeah.
from that point of view, it was good.
So as long as the valve, the Eberhard does not interfere with mitral valve, I think deeper position is okay.
Yeah,
Yeah.
I agree.
One more try, and
Okay.
just take what you have to take. Yeah.
Good suggestion. That might be the role to confirm it, the role of the imaging specialist
Test.
as well.
Okay.
We can
I
keep
think.
it there. Will be a good position. One marker band
Okay.
on the non-coronary side.
Release, please.
어제 박사님이 너무 감동을 받으셨는데 그 이제 하이브리드 메시
You want to pace?
와요.
No.
제대로 안 맞추면
The pacing 100.
Yeah, that's good.
Yeah.
That's good. Keep it there.
I do it slowly, okay?
Yeah, good. Okay.
There.
I was just going to say something, but I don't say it now. Okay. I think we have to keep it down there.
Yeah. But there's no lot of choice.
No other choice.
Test, please. Okay. One more try.
Yeah, but
Test, please. Okay. Okay. Test, please. Keep going.
I do it really slowly because then he can act.
Yeah.
He's on the high side again.
Push a little bit.
Yeah.
Little test. Yeah, maybe.
Test, please. Okay.
That's
Okay.
better.
Just aim for that side. Not much you can do. Left.
That's okay. You know,
Yeah.
Alan, I tell you what I think.
Yeah.
Because when we release.
Okay, it's time to the check is the mitral valve with the transesophageal cord.
Yeah.
Yeah. Can you see the
We can
image?
do that,
of
plus we
transverse
can do
cord?
the-
Yeah, no
the,
impingement
Not
of
bad.
the
Cohen.
mitral
It's
valve
good.
right now.
Yeah,
Yeah,
it's
good
good.
position.
That's good, thanks.
Yeah.
Look,
It's in the hinge point.
Could you check the leakage of our
Oh, okay.
aortic valve?
and
Oh,
you want to keep
We did
pacing?
not see the. 이거 화면 들어오게 해주세요.
페이싱 꺼주세요. 네. 네.
I think mild to moderate leakage from the mitral valve junction. Can you see the valvular leakage right here?
Yeah.
Yeah. Initial access image.
So Dr. Kim,
Yeah.
the,
So he's completely now.
Yeah,
can we deploy the valve at this time or not?
Oh, the
Based on
position is
your
good.
imaging interpretation.
Yeah, the degree of leakage it's about mild to more than mild to moderate. I think the 1 o'clock direction.
Here, there
You
is
have to decide. Give us
The
some
depth is
information.
important. The depth of the valve.
What is
But
the distal margin of the valve in the on
Yeah.
the mitral valve?
Yeah, it's just the depth. The leakage I don't care about at this point
Yeah.
because it's not
No,
lying.
to be honest, and I don't, well, I shouldn't say that here, but personally, I would release it because on
Yeah,
the
yeah, release
on the
it.
other side, you know, you don't interfere with the mitral valve. So
Right, right.
on the non-coronary side, the depth is quite good actually, and you
Yeah.
can see this on echo. And you know, there's always a chance for post-dilatation, so we can always do that.
And it will tilt a bit favorably too, I think, Eberhard.
So far, the body of the of the evolute is pre-aligned with the root.
Yeah.
It's just the top is pulled a bit, so you can see on echo it's not a big tension to pulling something. So I think we'll be okay.
Yeah, I think so
I would
too.
just
And-
go it because you know you were popping many times, so
Yeah.
not going to be anything better in a sense.
And the
Agree.
diastolic pressure right now is 60.
Yeah, 60.
So at least we got hemodynamically, you got good support. I mean, a good result.
Blood pressure is going up
Yeah.
than before. So
Okay, shall we go?
Go for it.
I
Yeah,
like to
go for it.
yeah, I like to
it.
test
Yeah,
the
I agree.
coronary.
Coronary?
Yes.
Shall we?
Ready?
Don't look at the PVL here because we are injecting
Okay.
outside. Oh
Coronary
yeah,
is
that's
good.
that's a
Coronary
lot of
looks wide.
Yeah.
space.
So one another option is if there is a significant PVL, we can put more valve.
Yeah, I
It
mean
could-
that's an option we always have, but
Yeah.
we have to anchor the first one way or the other.
Yeah.
And given the pop-outs that we had, trying to get it a little bit higher, I would probably release it here.
Okay. So
Shall we?
yeah.
Yep.
Let's go for it, Alan.
Yeah.
Yes, go for it.
Slow.
I do that. Yeah. See, the valve tilts already.
Yeah.
I mean, it's not going to do anything on the. Very good. I think we're okay. Okay.
Yep.
I like to remove whole system.
Very nice.
Dr. Kim, what is the opinion?
Wait a minute, but
The release.
I'm checking.
Well, let us just
the-
wait
the
until we get
parameter
our
located
technical
reduce.
stuff done.
Right now, the main is central layer. I think the power leakage is slightly decreased from the previous
Very
exam.
nice.
Yeah.
Beautiful.
Can you
Do
see
you
the
have
one,
the
one
additional balloon or the additional Eberhard R or what?
You know, why don't we just go step by step for
Just wait
a
a little
second?
bit. Just wait a little bit and, check the real pressure because the wire is tenting up the valve at the
Yeah,
leaflet
and
as well.
that one.
I think the
and
power leakage is just mild right now.
Let's
Yeah,
not
just
come
wait.
to.
Change the pigtail and just let
Exactly,
it
to-
relax a bit for
to,
a few minutes
Please make sure there is a central layer from the catheter. Yeah.
Okay.
from the wire. Yeah, it's a strong wire, so it push against
Yeah,
the one
let's
side.
take that out, and
Change the
I will check
pigtail
again.
and
Yeah.
the valve is in, and now
give it
we
a
can.
time.
Strong wire.
Evaluate.
Material from the central.
Yeah, you can see the wire the jet is coming right at the edge there to the non-coronary side.
스티브 해주세요.
But there's one thing that you could definitely say, Alan. The 23 would have not been a good choice.
Yeah, no, it would
Exactly.
be way too small, right? You
Yeah.
just-
Which, you know, it's always the dilemma with these diameters, you know. This release has to be done a little bit more carefully because of the lack of calcium, so we'll see.
리거지 해주고.
Remember, there's still that constraint, the suture line.
Yeah,
We'll see now.
it's interesting.
Yep.
Ready?
Coronary is okay.
And it's very mild.
You see the bypass graph?
Did somebody say okay?
Yeah,
Yes,
the bypass graph was okay. The coronaries
so-
are okay. The
yes.
coronaries okay.
Yeah.
I like to measure the LV pressure.
Yeah.
Yeah.
Okay.
I think the moderate central layer right.
Why don't you change out the safari wire to pigtail? I
Yeah.
think it's better.
Yeah.
Then you can see
Exactly.
the central AI is a bit
That's right.
confusing.
Yeah, very confusing.
I mean, you can see what's expected there, the leaks. He shows this very nicely. But you know, in a situation like that, I think it's worthwhile to just don't come to premature conclusions. I think we should, you know, establish the situation,
Yep.
and then decide. Patient is
Especially
okay,
core valve, it will take a few minutes for it to kind of
right?
settle down.
And the
as
patient is
well.
okay, you know.
Yeah, probability much reduced into trivial degree.
Yeah.
Well, it's definitely better than before.
Yeah.
Yes.
Yeah.
Exactly. Yeah.
Look at that.
Yeah, diastolic
No
pressure is
gradient,
what
no
if
gradient.
Trivial. Yeah, probability is.
I
from
think
1
it is.
o'clock
I think actually it's good. Oh, somebody is at least supporting us, not saying, "Oh, you okay?" He said it's
we don't need,
wonderful.
So I like to
Well-
remove the LV.
Yeah, remove the LV
Catheter
catheter and
and-
just get a best
yeah.
shot, see what's going on.
And then check
Then
the best
it's-
shot.
Yeah.
Ready?
Okay,
Come on, guys.
Oh, that's fantastic.
That's not
That's why
okay.
never
I think that's
inject when
great.
there's something inside the valve. It's you never know, right?
Yeah.
Until you take the stuff out, you never
You need a
know.
little cheering up here, you know. Okay, it's not enough. But it's
And
really
the
nice.
alignment is very good. It's actually sort of sitting. The core valve is using that. Evolute is using that suture line.
Yes.
There, right?
Yes, exactly.
In
It's
fact, that's
actually
probably helped it.
it's
It is stable in this situation.
yeah, and it's at the. It looks like it's at the waist almost, no? A little bit higher.
Yeah.
But anyway, the perfusion is good and the pressure is good. Now it's 60, and I'm actually really happy, to be honest.
Dr. Kim,
Yeah.
could you show us
Don't
the
destroy
echo?
us now.
The probability is just trivial right now. Yeah, excellent results.
Oh, that's it.
Oh, just trivial.
Yeah, just trivia. Yeah.
Wonderful.
congratulations. Yeah. Can you see 1 o'clock fraction? Yeah. Just
This is really, really nice.
Yeah, it's wonderful.
Given 4 pop-outs, he stayed cool.
The final angel show that the distal margin of the evolute are a little bit deeper, but the transesophageal echocardiographic finding is the very happy finding.
Yeah.
It's
Yeah.
some
Yeah.
discrepancy between the fluoroscopic and
Ready?
the imaging. So that is the role of the imaging specialist during the procedure.
Thank you very much, doctor.
The tricky part about the prima root is that the suturing, which is your kind of annulus, is lower than the sinus.
Yes.
So you actually looks like it is deep, but it's actually relative to whatever the surgical suturing is probably a little deep, but not like as deep as you think.
Yeah.
And that's why it gives you, why is it sealing so well? Is that because the suturing is actually lower. The porcine sinus is sitting on top of it. And it's not like the natural, so it's really an annulus that is more real than our theoretical annulus in our native aortic disease. So I think that's why you have such a good seal and it looks like angiographically, oh no, it is too deep, right? So I think that's a really excellent result.
Right.
It's good. So I think if you're happy, we certainly are.
Yeah.
And
I'm very happy.
Again, yes.
Excellent job.
And, we will see you in a second, and thank you
Yes.
very much.
Thank
for
you.
your
Thank
time.
you.
Great job. Great job
Okay,
going
good.
to Dr. DW
Yeah,
Mark as well.
okay.
I think you're standing in the back to
Okay,
give
okay,
us
got
some
it.
take-home message.
Okay,
and,
so
wrap up.
Okay, this is I'm gonna do the closing remark here. Is I have no enough time to go back to the auditorium. All the live demonstration this year is finished well. So all case was successful, even though the last day case, some amazing. So I think this year's successful meeting was definitely done by our sincere faculty. Is really appreciate all the faculty to contribution to our meeting. I think this year our meeting is completed well. For next meeting next year, we also prepare more diverse, more variety live case demonstration and also updated knowledge about the TAVR and the valve intervention procedure. Once again, really appreciate all faculty contribution and Dr. Grube, Dr. Allen Young, is all faculty, and once again, and really appreciate the audience, and finally, really appreciate our team. Thank you.
Thank you very much.
Thank you.
Excellent.
Thank you.
Take care.
See you next
Thank
year.
you so much. See you soon.